Andrea Soares, who comes to us from California. She graduated from UCLA with a degree in molecular cell and developmental biology, and then came to St. Louis for medical school. She's homegrown, graduated from WSM, and then joined our residency program in 2018. As part of her residency training, she applied for and was accepted to the WUTIP program, which for those of you who aren't familiar with WUTIP, it's our clinician educator training program for residents, and now we also offer it to fellows. As part of this program, I've had the honor of watching Andrea's professional growth as an excellent teacher, an outstanding curriculum developer, and an outstanding scholar. And as part of her education scholarship project for WUTIP, she completed several projects. Andrea is the kind of person that gets everything done. And when I ask her to do something, it's already done yesterday. So she's really impressed me, and it's been an honor to get to know her. So she's going to present some of her work today and also talk about women in medicine in general, then and now. Andrea?
Good morning, everyone, and welcome to those of you joining us on Zoom. Thank you, Dr. Cal, for that wonderful introduction. Today, we will be discussing the topic of women in medicine. My name is Andrea Soares, and I am a third-year internal medicine resident here at Washington University School of Medicine in St. Louis. I will start by discussing a very brief history of women in medicine in the United States specifically. I will then discuss challenges that women in medicine face today. Next, I will focus on my own research on gender stereotype threat in residents and challenges reported by women in dual physician couples, particularly during the current coronavirus pandemic. Finally, I offer some solutions to particular challenges faced by women physicians. On the left of your screen is a portrait of Elizabeth Blackwell, the first woman physician in the United States. Dr. Blackwell was originally a teacher, but was inspired to practice medicine after a close friend of hers died, stating that she wished that she had had a female doctor. At the time, the mid-1800s, no medical colleges accepted women. In fact, Dr. Blackwell was rejected by every medical school to which she applied, except for the Geneva Medical College in Geneva, New York. Her universal acceptance was actually a practical joke from her male classmates. Despite all of the adversity she faced, she still graduated first in her class in 1849. On the right of your screen is Rebecca Lee Crumpler, the first African-American woman in the United States to graduate from medical school. Prior to this, she had been a nurse for 8 years. She graduated from the New England Female Medical College in 1864. She initially practiced in Boston, but after the Civil War, moved to Richmond, Virginia, where she cared for freed former slaves who previously had not been able to receive medical care. In the United States, discrimination in medicine truly happened from the top down. In the late 19th century, Johns Hopkins University was the preeminent medical college in the United States and set the tone for all other universities. The university's first president, Daniel Coit Gilman, called co-education a thoroughly wrong idea that was rapidly disappearing. His reasons for not admitting women included, 1, that students might fall in love, which could have disastrous consequences. 2, that women might have trouble keeping up with the rigorous academic pace. 3, that women might fall ill due to severe stress, thereby destroying their chance of a good marriage. And 4, that a woman's future was so different from a man's that there was no point in co-educating them together. So what prompted a change? Because clearly there was one. In 1889, the medical school had no money to open. Their income that had previously been received from the university's B&O railroad stock was no longer available. 4 of the university's trustees, all rich women involved in the feminist movement and all unmarried, offered a deal. One of those women, Mary Elizabeth Garrett, can be seen on this slide. The women offered to raise $500,000 to open the school and pay for a new building if the school would open its doors to women. As time went on and attitudes very gradually changed, women gradually began to make up a larger percentage of the physician workforce throughout the world. In Germany, in the 1960s, women comprised 30% of the physician workforce. This number was 20% in the Netherlands, 25% in Great Britain, but meanwhile, in the United States, women made up only 6.6% of the physician workforce. In the United States, barriers still remained to women pursuing careers in medicine, including rigid quotas or institutions simply not allowing women to be admitted. However, starting in the late 1960s, the revival of the feminist movement gained momentum, and the number of women entering medicine rapidly grew. By 1980, nearly 30% of incoming medical students were women. We will now shift our focus to medical school data trends, and here we have the first-year class of Washington University in St. Louis taking their modified Hippocratic Oath. Here you can see the number of applicants to US medical schools by sex between the 1980 academic year and the 2018 academic year. Women are represented in purple and men are represented in teal. You can see the number of women gradually increasing until it reaches parity with the number of men in 2002 to 2003. You can also see that in the 2018 academic year, the number of women applicants was actually larger than the number of male applicants. This next graph shows the historical trend of medical school graduates by sex within that same period of time. Women are again represented in purple, and men are again represented in teal. By 2007 to 2008, the number of women that graduated from medical school was equal to the number of men. But after this, men again surpassed women for nearly a decade. Just to give you some real numbers, in 2018 to 2019, 47.9% of graduates from medical school were women, compared to only 24.9% in 1980 to 1981. We will next shift our focus to data on practicing physicians in the community. Here, we see the percentage of physicians in the United States by sex. Women are again in purple and men are again in teal. By 2018, 64.1% of physicians were men, compared to 35.8% who were women. In real numbers, this equates to 588,000 male physicians compared to 328,000 female physicians. However, despite this increasing parity in numbers, women continue to face many inequities in medicine. This includes lower salaries, limited availability of mentorship, less research funding, underrepresentation in awards, and a lack of flexibility in work schedules. A 2017 survey found that male primary care physicians made an average of $229,000 annually, compared with $197,000 on average for women, a gap of 16%. This gap becomes even more pronounced in specialists, with men earning $345,000 annually, compared to an average of $251,000 in women. In academic medicine, female physicians made an average of $228,000 annually, compared with an average of $247,000 annually for male physicians, after adjusting for faculty rank, age, years since residency, specialty, funding from the NIH, clinical trial participation, publication count, and total Medicare payments. Beyond financial compensation, there are certain specialties that are thought to be more friendly towards women. In general, these have traditionally included internal medicine, pediatrics, psychiatry, OBGYN, and family medicine. However, even within medicine, certain subspecialties have issues recruiting women. One of these, as you can probably tell from this slide, is cardiology. Women currently comprise less than 15% of practicing cardiologists and less than 5% of interventional cardiologists. Gender inequality within cardiology and interventional cardiology is similar to that seen in orthopedics and general surgery. However, this graph tells a different story. This model looks at past and present Australian gender proportions within cardiologists and trainees. This line represents the proportion of male general surgeons over time, which, if their rates of projection continue, will roughly reach equality with female general surgeons around the year 2050. You can see the trend of male cardiologists over time and female cardiologists over time as well. This shows that gender parity in cardiology will not be achieved within 50 years if these trends continue, and that cardiology actually lags behind general surgery. Although this model is based on Australia, and we like to think that the United States is more progressive, the proportion of female cardiologists in Australia is actually 14%, compared to only 13% in the United States. While the increase of female general surgery trainees in the US is 0.9% per year, it is only 0.3% for female cardiology trainees. In academic medicine, women are most highly represented at the early faculty level. Currently, in terms of promotion, women comprise 38% of full-time medical school faculty, but only 21% of full professors, 15% of department chairs, and 16% of deans. Initially, this was attributed to the fact that most female physicians were relatively young compared to their male counterparts, so that senior academic and administrative appointments went to older individuals. However, from 1980 to 1995, proportions remained fairly stable, and in 2015, the numbers of women were only slightly higher. A major barrier to the advancement of women in medicine is the centrality of research in advancement in academics. This study focused on early career physician scientist recipients of NIH K08 and K23 awards from 2006 to 2009. The study intentionally focused on recent younger recipients of these highly competitive grants in order to capture women who had invested a great deal of time into their early careers and who had been raised when it was more common for mothers to work outside the home. The results showed that female physicians with children spent an additional 8.5 more hours per week on domestic activities compared to their male counterparts. In total, they spent 43.8% of their time on parenting or domestic tasks compared to 25.2% in their male counterparts. Female gender was associated with less time spent on research and less after-hours ease of work completion compared to men. Prominent women faculty have often described the difficulties of raising children while continuing academic research, writing manuscripts late at night, minimizing work-related travel in order to care for their families, and leaving their laboratories to tend to sick children. We obviously do not have time to discuss all of the disparities that women face in healthcare today and all of the possible solutions. However, I just wanted to touch on a few. Many studies document the lower salaries of women physicians compared to their male counterparts, and we've gone over some of that data today. Generally, this issue starts at the time of initial appointment. Because raises are based on initial amount, the lower starting salary of female physicians propagates so that they end their careers with lower salaries as well. Suggested solutions for this include transparency of starting salaries to equip early career faculty to make professional decisions. Next, women should be trained in the initiation of negotiating salaries and packages to support their financial and academic goals. Here we see an image from the Forum for Women in Internal Medicine contract negotiation workshop that was given last year in October. Women face many challenges in negotiation compared to men, based on differences in approaches to negotiation and differences in how they are perceived by the other side. Finally, leadership should be trained in implicit bias to recognize its potential impact on the hiring process. Another key issue that women face is discrepancies in mentorship. One prior study has shown that 13% of women faculty have never had a mentor, and that an additional 34% did not have current mentors. Suggested solutions for this include that professional societies can sponsor cross-institutional programs. Institutions can perform faculty development needs assessments. Mentorship programs focused on women can be instituted. And finally, programs should specifically focus on skills in scholarship, grant writing, and leadership. We will next shift our focus to discussing my research on women in medicine. This first study focused on stereotype threat, which is a prominent contributor to the underrepresentation of women in leadership positions in academic medicine. Stereotype threat is defined as a situational predicament in which individuals are at risk of confirming negative stereotypes about their group. This study focused on the interaction between stereotype threat, gender, and mindset. In general, people can be grouped as having either a growth or a fixed mindset. A growth mindset generally means that individuals believe that intelligence can be changed, while individuals with a fixed mindset believe you are born with a certain amount of intelligence and that's it. This study looked at stereotype threat on the resident, faculty, and society levels. The following data are based on a survey of 77 internal medicine residents, 33 of whom were women. We first looked at the interaction between gender and stereotype threat and found there was no statistically significant difference between men and women and their perception of stereotype threat from others at the resident, faculty, or society level. Our hypothesis was that regardless of gender, a fixed mindset would be associated with increased perception of stereotype threat. However, when we looked at mindset and stereotype threat, we again found no statistically significant difference between individuals with a fixed and a growth mindset and their stereotype threat perception. We then used a multiple linear regression model to look at the effect of gender and stereotype threat to see if mindset was a mediating factor. We found that individuals with a fixed mindset, in particular, women, reported more stereotype threat perception than their male counterparts, than their female counterparts with a growth mindset. We found that mindset did not have an impact on men's perception of stereotype threat. This is important because stereotype threat has been associated with increased burnout and decreased career satisfaction. So it is important to implement interventions to foster a growth mindset in women. Our next study focused on women in dual physician households, specifically during the coronavirus pandemic. We circulated a survey through email and various social media websites and looked at data from around 1,800 respondents, all members of dual physician households. 97% of respondents worked here in the US. Over 80% were between the ages of 30 to 49, 36% resided in the Midwest, 80% were from non-surgical specialties, and 81% were women. We first looked at how COVID-19 was affecting men versus women in their workplace. Generally, male physicians were more likely to be caring for COVID-19 patients and more likely to be working in the ICU or in the emergency department. The difference between the two sexes was statistically significant and very interesting when looking at the rest of the data. We then looked at feeling emotionally and physically drained during the pandemic compared to prior to the pandemic and exhaustion levels. The numbers in parentheses represent percentages. You can see that a greater percentage of women reported feeling more emotionally and physically drained during the pandemic compared to prior to the pandemic, despite the fact that men were more likely to be caring for COVID-19 patients. A greater percentage of women were also more likely to report an exhaustion level between 7 to 10. We then looked at time spent on household duties and time spent with children. Women are represented in this column and men are represented to the right. Unsurprisingly, a greater percentage of women reported spending increased time on household duties and increased time with their children. The question is, was this increase in time spent on household duties and childcare affecting women's work output during the pandemic? The short answer is yes. One study showed that the proportion of women-first authors during the pandemic was 19% lower than for papers published in the same journals in 2019, which is consistent with the idea that research productivity in women has been more affected than research productivity of men during the pandemic. Another study, actually done by researchers here at WashU on the undergrad campus, showed that mothers' work hours had dropped 4 to 5 times as much as fathers, particularly in women with younger children, although this study was not solely focused on physicians. In summary, from Elizabeth Blackwell in 1949 to the present day, women in medicine have come a long way. While the number of women graduates from medical school has become roughly equal to the number of male graduates from medical school, women face many disparities still in academic medicine, particularly in terms of salary, promotion, mentorship, and recognition. Fixed mindsets in female physicians are associated with increased stereotype threat perception, which can have deleterious effects on a woman's career. The current coronavirus pandemic has only served to heighten gender discrepancies in medicine in the United States. Institutions, therefore, need to implement interventions to help correct these disparities. I would like to thank all of you for listening to this presentation today, especially those of you in this room. I would like to especially thank Dr. Frazier, Dr. Costco, and the Chiefs for the opportunity to present today. I would like to thank Dr. Cao and Dr. Bayani for all your mentorship with my research projects, FWIM, and WUTIC, and for helping me in preparing this presentation. I would like to thank Dr. Ludmerer for his assistance with the statistics and with the historical portions of this presentation. I would like to thank WUTIC and MIMS for supporting the various research projects discussed today. I would like to thank my fellow residents for your encouragement and for listening to me practice. And I would like to especially thank my family, particularly my mother, who can be seen here on this slide at my graduation from WashU School of Medicine, who was my first female physician role model. Thank you.
Good morning. This morning, I have the pleasure of introducing our next speaker, Dr. Doug Kerouac. Doug went to undergraduate at University of Notre Dame, where he then went to the Ohio State for Medical School. He was honored there with the Gold Humanism Award and being AOA. We were very lucky to recruit him to be here with us for residency. As a resident, he's done an excellent job, excelling really in every area. He's conducted multiple quality improvement projects and handoffs in CHF patients at the VA. He's also been very active in our wellness committee, thinking about ways that we can improve the residency for everyone. And then he's also been an outstanding clinician and excellent researcher. So today he's going to talk to us about the arm as a window to the heart. So I'm very excited to hear about his talk.
First off, thank you, Dr. Fondon, for that lovely introduction. I'm so excited to come talk to you guys about something I'm fairly passionate about, arm exercise ergometer. And usually right here, what I would do for you guys would be to show you a video to give you a visualization of what we're going to be talking about. However, with all of the issues with Zoom, I'm a little bit worried to do that right now. So let me give you kind of a mental picture instead. So the arm ergometer is essentially a bicycle that you pedal with your hands. So it's an upright bicycle that you're going to be pedaling with your arms to create some kind of work. And I'd like to tell you about how this could be a modality for stress test. Let's see. I am going to interrupt this talk at periods of time because we just went on our honeymoon, my wife Becca and I, and we went to Lake Tahoe. And so I was hoping that I could take you through a hike on this talk and then interrupt it every once in a while. Let's start our talk with a case. So we have a patient, C.A. Dean. He's a 57-year-old who's coming into your clinic. He has a history of hypertension, hyperlipidemia, and he has a left below the knee amputation. He says that he's been going to the gym every day and has been doing the cycle rower machine, where he's been going for about 20 minutes at a time, but notice that he's been having chest pain about 10 minutes in. He has an absolutely normal ECG and an echocardiogram. So the question that is posed to you as his referring physician is, what type of stress test would be best for him? So is it a dobutamine echocardiogram stress test? Is it an arm ergometer exercise stress test? Is it a treadmill stress test? Or is it a Regression nuclear stress test? And I'd like to walk you through some of the old data as well as some of the new data that Dr. Martin and I have been working on to answer that question. So here's the outline of what we're going to be talking about. We'll start with some of the old data, talk about the treadmill data first, because that's what our foundation is based off of. Then we'll talk about some of the old arm data. And then we'll start talking about the imaging modality, whether ECG or myocardial perfusion imaging or MPI is a better imaging modality for your stress test. And then we'll talk a little bit about some of the prospective work that we've done. So comparing treadmill ECG with the arm test versus a Regression MPI or RMPI. And then we'll talk a little bit about future directions of where our work should go going from here. So the first question is, should patients exercise or not? And the main paradigm that I want to get across to you guys throughout this talk today is that the exercise stress tests are the ones that provide both diagnostic information as well as prognostic information, and how that has implications for our patients going forward. So the original work was done by a group over at Duke that was published in the New England Journal of Medicine back in 1991. They came up with this score called the Duke treadmill score. And what it did was it estimated the 4-year cardiovascular mortality for these patients. They put together the exercise time, as you can see here, the number of ST segment changes from baseline, as well as an exercise angina index. And that exercise angina index is quantified by the patient. So when they're doing their treadmill stress test, they will tell you that they're having no chest pain, that they're having a little bit of chest pain, but they can keep going, which would be a 1, or they're having chest pain, they have to stop. That's a 2. Out of this score, we can estimate roughly the annual incidence of cardiovascular mortality. And for low risk groups, so a score of 5 or greater, they have a low risk of mortality of 0.5%. But the people who have a high risk of mortality or a high score of -11 or greater, those are the patients that have at least a 5% or greater mortality annually. Here's some data that corroborates that original study for the Duke treadmill stress test score. And this looks at all-cause mortality for patients both with and without coronary artery disease. And what this tells us is that as you're able to do more metabolic equivalents or METs, then you have a lower risk of death. And this is looking again at the all-cause mortality. In case you were wondering what a MET is, which at the beginning of this, I kind of was myself. One MET is you sitting quietly in a room, as I'm sure most of you guys are at home. And then 4 METs would be walking up a hill 1 to 2 blocks. So just putting that into reference for you. The other major predictor that came out after the Duke score was the relative risk of death according to the heart rate recovery. And so this is another thing that was actually very interesting. And what it looks at is your heart rate 1 minute after you're done exercise as compared to your peak exercise heart rate. And what you can see here is that it's broken out into quintiles. And as you go through the quintiles, the more you were able to recover your heart rate after your exercise, the less likely you were to die. And once again, this is looking at the all-cause mortality for these patients over 6 years. So hopefully I've explained some of the rationale behind exercise. But the question is, what can you do if you can't do an exercise treadmill? Is there an alternative, and when do you have to avoid it? So first off here, about 50% of our patients aren't able to do a treadmill for one of these reasons listed on the slide. Which begs the question, is there an alternative? And as I mentioned at the beginning, I'd like to take you on a hike through this old data, some of these old rocks, if you will. There was a retrospective review of patients over at the VA where they looked at patients who underwent ARM ergometer as an alternative stress test modality. And we can go back to the picture here, I think a couple slides ago. Oh, excuse me. I think it got cut out. Anyhow, so the ARM ergometer, there were 450 patients over at the VA between 1997 and 2002 who underwent an ARM ergometer, or basically an ARM exercise bicycle. And then there were 1,700 patients who underwent a pharmacologic myocardial perfusion imaging. This is looking at that retrospective data and doing an analogous score as compared to the Duke treadmill score. So this graph here looks at the ARM exercise capacity for those patients who did the ARM ergometer. And what this shows us is those patients who were able to do greater than 3.6 METs had a better mortality or survival out to 12 years here. And then similarly, as a corollary, the recovery heart rate additionally had that prognostic value. So again, the green line at top clearly separates from the blue line at the bottom if you had a recovery heart rate of greater than 21 beats per minute as compared to those who had less than 12 beats per minute recovery. Here the hazard ratio is about 0.61. Finally, the other analogous thing to the Duke score was the ST segment changes. So those patients who had ST segment changes, as you might imagine, did worse off as compared to those who didn't have ST segment changes. Blue line being those who had no changes, and the red line being those who did have changes. This was formulated into an analogous score for the ARM ergometer stress test. And what the variables that we found were significant were the heart rate recovery, the number of METs the patients were able to complete, and the ST segment changes. As you can notice on the right side is the area under the curve, and that adjusted area under the curve, or the C statistic, was remarkably similar to the C statistic that the group found for the Duke treadmill score. This is taking a look at the Kaplan-Meier survival curve. When you break it down into those patients who have a high risk score in the blue, so if you had a score of less than 36.5 as compared to those who had a low risk score of greater than 36.5. And what you can see here is the 5-year all-cause mortality clearly separates. There's 5-year cardiovascular mortality and 12-year all-cause and cardiovascular mortality that look very similar to this graph here. And then lastly, when you break it down into those patients who underwent the pharmacologic myocardial perfusion imaging as compared to the ARM exercise MPI, we asked the question of, does that data still stand? And so as you can see on the right, the ARM exercise MPI, those curves seem to clearly delineate. And this is looking at the all-cause mortality, and once again, out to 12 years. That one clearly separates. However, on the left, the curve doesn't seem to separate. So there's something about the pharmacologic MPI that doesn't predict all-cause mortality. And looking at that in a different way, looking at the receiver operator curve, seeing kind of that goodness of fit or the sensitivity versus specificity, as you can see in the upper right is the ARM score that we calculated. And then in the bottom left, or sorry, the bottom right is the abnormal pharmacologic stress test. And what you see here is that the ARM score clearly did a better job at predicting the 5-year all-cause mortality as compared to a pharmacologic stress test. So hopefully I've been able to convince you a little bit that exercise is important during your stress test. But the next question becomes, is ECG or MPI, the myocardial perfusion imaging, a better modality to assess the patient? So continuing with our theme of powerful prognostic variables, first we looked at the clinical data and what was clinically significant at predicting mortality out to 12 years. And so when you add the demographics plus the clinical information, plus the number of METs attained and the heart rate at 1 minute post-exercise, that seemed to provide the greatest discrimination in terms of their all-cause mortality out to 12 years. When you added the change in heart rate, that variable seemed to not really add an additional benefit because it was so highly correlated probably with the heart rate at 1 minute after exercise as well as the number of METs. Again, with the theme of more variables being better, what about if we add in the MPI? And so here, we progressively added age plus the number of METs plus the MPI test. And what it looks like is that it clearly predicts death or myocardial infarction. But that begs the question, what if you use an ECG rather than the MPI? Does that provide you the same benefit of data? And here what I'm showing you is as you add together the age, the clinical data from that first slide, the number of METs attained, and then either the ECG or MPI, those are the two that are highlighted here. And what you can see is those bars are essentially the same size. And what that's telling us is that the MPI is telling us pretty much the exact same prognostic information as the ECG. And what that led our group to decide is that the MPI is probably a suitable test when you can't do an ECG. So going into some of the indications for MPI, some of the reasons why you might want to do it would be if you can't have an interpretable ECG on the patient. So this would include anything from a ventricular paced rhythm, a left bundle branch block, ST deviation at baseline, as well as the other thing is if patients weren't able to attain at least 69% of their age predicted maximal heart rate, that's when the myocardial perfusion imaging seemed to do better than that ECG. Some of the limitations of the MPI includes that it doesn't really provide the added benefit of prognostic as well as diagnostic information that the ECG exercise stress test does. And it doesn't really fit with the physiology of the exercise that the patient's doing. Number two, it provides radiation to both the patient as well as the people who are performing the test. Number three, it's time consuming, it's space consuming. You have to dedicate an entire lab for these MPI studies. It's expensive, greater than 10-fold. And then once again, it's expensive in terms of equipment and personnel. One of the patients that highlighted some of this earlier information for us is one of the patients over at the VA. And this guy was needing preoperative clearance for a surgery. And the first test that he underwent was a myocardial perfusion imaging. And what you can see here is that it is essentially a normal test. and it was read by the VA radiology attending as normal myocardial perfusion, rest, and stress. This guy was a high-risk candidate, and so he later underwent the ARM exercise MPI, as he had a below-the-knee amputation and wasn't able to do the treadmill. And so this is looking at his baseline ECG. And what you can see is that it is interpretable. There's no ST changes. He seems to have a normal rate and a normal rhythm at baseline. However, he starts exercising. He begins to have chest pain at the end of his exercise. And this is looking at the end of his exercise ECG. You see that he's starting to have some ectopy, and there might be some ST changes there. This is really concerning for us. This persisted out to 1 minute and 30 seconds. Here you can see that the ST depressions are really prominent. If we look at 1, 2, leads V4 or V5, you can really see those prominent ST depressions. And there's even an elevation of AVR there. Up to 5 minutes, these ST depressions were still there. So this was a wildly positive stress test for this guy who had undergone an MPI and it was normal, and then his ARM ergometer was wildly positive. So this led us into new horizons, some new data, looking at some of the stuff that we've been doing over at the VA lately. So over the last year and a half, there have been 170 patients randomized into completing the ARM ergometer ECG stress test, the exercise treadmill stress test, or ETT, and the Regadenoson MPI, or RMPI. These patients would complete each of these tests successively in a randomized order on separate days. And what we were looking at is how these tests compare to each other, both in terms of the anatomic outcomes, so whether they had coronary artery disease, and their prognostic outcomes in terms of whether they had a heart attack or PCI or CABG. And so as we may know, those outcomes are not necessarily the same. Here's the baseline characteristics for the patients. It was a typical VA population. There were 104 patients who completed so far all 3 of those tests. Something that was notable is they were 97% men, as kind of a reference back to Andrea's talk. There aren't very many female over at the VA. This was a high-risk cohort. There was a high propensity of hypertension, hyperlipidemia in our patients, and then a number of them had previous CAD, as we can tell from they had a previous MI, prior PCI, or a prior CABG. And so initially looking at the exercise parameters in terms of how the ARM compared to the treadmill stress test, the number of METs that were completed on the treadmill were about twice the amount of the ARM. And this doesn't necessarily mean that the ARM is a bad test. What it means is that you're using larger muscles when you're walking on the treadmill as compared to when you're cycling with an ARM ergometer. And that would be predictable that when you're using larger muscles, you're able to do more work. That was, as you can see in the right-hand column, highly statistically significant as well as clinically significant, and why those 2 formulas that I showed earlier in our talk have different constants in front of the number of METs attained. When you look at these other variables, the heart rate, the systolic blood pressure, and the heart rate blood pressure product, while they are statistically significant, they're within about 10% of each other, and so it's probably not as clinically significant, and not something that you would notice on an individual patient who came in. So what we really cared about was, what's the receiver operator curve, or the sensitivity and specificity for these 2 tests? And this is looking at predicting MI or coronary revascularization when the patients underwent either an ARM or an exercise treadmill stress test. And what's important here is the area under these 2 curves is about the same. The ARM was a little bit more specific, whereas the treadmill was a little bit more sensitive. Then moving on to the RMPI as compared to the ARM, what we see here is that the physiologic variables, the heart rate, the blood pressure, whether angina was elicited, was much more readily available with the ARM test as compared to the RMPI. the RMPI did provide us that additional information on whether they had perfusion deficits on the imaging. And that's important to keep in mind because that can tell you where the coronary artery disease is and what territory is affected. So then we looked at the predictive ability of the ARM and the RMPI to identify what we defined as significant 3-vessel coronary artery disease. And so what this meant was either greater than or equal to 70% stenosis of the left main or all of the coronary arteries. And what we're looking at here is the sensitivity, specificity, and the predictive values of these tests look to be about the same. And so this would lead us to believe that the ARM is at least as good of a test of predicting these anatomic variables. So lastly, what we looked at was an outcome study. So looking at a composite clinical outcome out to 1 year of whether the patients experienced sudden death, myocardial infarction, CABG, or PCI. And what this shows is the ARM is in the top row as compared to the RMPI in the next two, and then the treadmill at the bottom. What we're looking at here is the predictive value of these 3 tests. And what I really want to focus on is that top column, showing that the ARM predictive value seems to be at least as good as the other 2 tests. Excuse me. Excuse me. Some take-home points that I wanted to leave you guys with here. So number 1, exercise stress testing, both ETT and ARM, provide that diagnostic as well as prognostic information. And that's really important to know whether our patients are going to be able to survive over the next 5 years. Number 2, the number of METs attained during their exercise stress test is highly predictive of their future mortality. Number 3, the ARM test is an underused alternative stress test to those who can't perform the treadmill. And this is important because at Barnes, we don't even have an ARM ergometer at this time. It's only available at the VA. And then lastly, ARM may be a lower cost alternative to MPI without many of the associated risks, including the radiation. Some of the future directions we'd like to look into is, right now we have outcome data out to 1 year. We would like to look at the 2 years, the 3 years, and the 5 years outcome data, because that'll give us a little bit more information to see if the ARM predictor is still robust at those time points. Number 2, the mortality for the patients who were sent for revascularization, whether it be through the ARM data or through the RMPI. I think that'll be important because when you have the RMPI, it tells you specifically where the lesion is and whether you should be targeting that lesion or not. And then number 3, our RMPI sensitivity, if we look back at our different charts, was a little bit lower than you would anticipate from the historical data. The historical data quotes about 80 to 90% sensitivity, where we had quoted about 50 to 60% sensitivity. And that may be due to a number of reasons. Number 1, it could be due to this being a real world type of study of patients who are coming in for chest pain. Number 2, it could be that the patients over at the VA were more likely to have 3-vessel or balanced ischemia, and thus lowering the sensitivity of the MPI. Or number 3, it could be something idiosyncratic about either a population or the location at which they were receiving the test. And that's something that we would like to look into further in the future. The last thing you may notice that many of our patients over here get a dobutamine echo as their alternative stress test modality. To our knowledge, there's not a whole lot of data with ARM and echo. And that's something that we would like to look to do in the future. Going back to our case, hopefully I've been able to explain to you that our patient who is able to exercise but unable to do a treadmill stress test, that an ARM ergometer might be a good alternative stress test for these patients. And then lastly, I'd like to leave you with this. This was a photo from our recent stress test over at Lake Tahoe, where we summited Mount Talac. And we certainly completed greater than 4 months of work. I wanted to thank everyone who made this possible. Thank you. Excuse me. Good time for a couple questions.
Yes, we do have time for a couple questions now. Go ahead and feel free to submit through the Q&A for those of you who are listening via Zoom. I can start by addressing the speakers here with some questions. Thank you for your wonderful talks. Can you guys come back up to the podium? Okay. So one question I had for Andrea, you mentioned on this fixed versus growth mindset. Can you expand a little bit more about that and how someone with a fixed mindset could find their way to obtaining a growth mindset?
So a lot of studies that have focused on mindset have actually shown that if you give students,
Ramp up your volume when you're talking through your
oh, I'll just take it off. So I think a lot of studies that have focused on mindset have actually shown that if you give students some instructions prior to a test that are gender biased in some way or biased towards them in some way, that will actually lead to them developing somewhat of a fixed mindset even before taking a test. So there are different interventions that you can do to help foster a growth mindset. You can give people articles that prove that intelligence can be changed over time, have them read that, and doing interventions like that can help shift their mindset. And I think that Steve is actually working on a project like that right now, as is Justin, I believe.
Thank you, Andrea. And then one question I had for Doug here. So you mentioned that this ARM ergometer is available at the VA, not available at Barnes. Are there other VAs throughout the nation or other medical centers that are also utilizing this technology and also performing studies, or is this pretty unique to our VA here and the work that you're doing with Dr. Martin?
So there are some other institutions who are using the ARM ergometer, but it's not widespread use and something that we would like to promote in the future.
And then one other question for you. You mentioned the use of debutamine stress echo and how that an ARM ergometer could be used to obtain imaging, stress imaging that way. Have there been any studies, just, here we use so much debutamine stress echo as our usual stress imaging. Have you compared the ARM ergometer to the data that's obtained through stress echo?
We haven't been able to do that yet, but it's something that we look forward to doing in the future.
Okay, I think that's wraps up the Q&A session here. I have the QR codes that I will work on getting to share with you guys. Thank you for being here today for our second session of the Grand Rounds. We'll continue next week with 2 other additional Soares speakers.